Good evening and welcome to the 30th meeting of the Health, Social Care and Sport Committee in 2024. I've received no apologies for the meeting. The first item on our agenda is to agree to take agenda item 3 in private. Are members agreed? Thank you. The second item on our agenda is to continue our scrutiny of the Assisted Dying for Terminally Ill Adults Scotland Bill at stage 1. Today's session is with those involved in the application of assisted dying law in Canada, and all of our witnesses are remote. And I welcome to the committee Dr. Ramona Cahello, physician and member of the Medical Assistance in Dying Death Review Committee of Ontario, Canada. She joins us in a personal capacity and not on behalf of any organisation. And Dr. Stephanie Green, MAID practitioner, founding president of the Canadian Association of MAID Assessors and Providers, and advisor to British Columbia Ministry of Health. Thank you both for joining us today, and we are going to move straight to questions. And Paul Sweeney.
Thank you, Convener, and thank you to our panel members for joining us this evening, or I'm not sure what time zone difference is, maybe early in the afternoon at your end, but appreciate the time. Perhaps, Dr. Green, if I could start with you and move on. Just to ask on palliative care, is there any evidence that poor palliative care is acting as a driver for people to seek assisted death in Canada?
Great. Are you all able to hear me? Is the muting working?
Yeah, I can hear you.
Yeah, great. Thanks. Thank you for the invitation to be here today. I appreciate the question. I'm happy to tell you that we now have 8 years of experience in Canada and over 6 years of data to look at. And in fact, palliative care and MAID, of course, are not mutually exclusive. We've actually seen a shift in growing involvement of MAID doctors in palliative care doctors in MAID. But specifically to your question, is there a lack of access? Is poor access to palliative care a driver of MAID in Canada? I'm happy to say we've got really good data showing us quite the opposite. We know from our national reports where we've seen practitioners talk about whether their patients have had access to or are receiving palliative care. And we know from provincial reports where nurse investigators from coroner offices speak to families and comb through reports, their numbers as well. And we can see that 96% of people who've received MAID in Canada have had access to palliative care, and roughly 80% of them are actually receiving palliative care at the time of their MAID death. So it's you can't really look at those numbers and conclude that MAID is in any way driven to any degree by lack of access to palliative care. I think it's important to look in another way as well, because I think that data is clear. But we also know from a lot of data that those with cancer, certainly in Canada, will, compared to those with other diagnoses, will absolutely get better access to palliative care. We know they're twice as likely to receive palliative care in Ontario. We know they get it earlier, that the median for those to receive palliative care is 3 months before death as opposed to 3 weeks. And we know that palliative care will be of better quality, that they're 4 times as likely to receive palliative care at home compared to those with other diagnoses. So if you consider 2 patients, one with lung cancer and one with lung disease, like emphysema or chronic obstructive pulmonary disease, you've got 2 patients with essentially the same symptoms and potentially the same degree of suffering, but one is receiving substantially better palliative care, the one with the cancer. If you believe that access to palliative care would reduce the incidence of assisted dying, you would expect a dramatically lower incidence of MAID in the group that's receiving the better palliative care. But in fact, you see the exact opposite in the data. The higher numbers of people with cancer are asking for and receiving medical assistance in dying in Canada than any other group. It's simply not possible to conclude that MAID is being driven to any degree by a lack of access to palliative care.
That's great. And Dr. Coelho, do you have any further comments to make in relation to that question?
Yes, please. Thanks for having me here as well. And my response is I reached out to the Canadian Society of Palliative Medicine, so my statements are from their board. They're all evidence-based, and I'm willing to submit the evidence after this session. So palliative care is different from MAID in that it's sets to handle existential suffering, physical and mental suffering, and look for physical supports to help a person live well and not hasten death. They are ethically distinct, and palliative care should be a clinical and legal safeguard to prevent people feeling driven or desperate to choose medical assistance in dying. And their words, we see the diversion of limited palliative care resources to support MAID and the potential for patients refusing palliative care services now for fear that somehow it will hasten their death. The power imbalance between healthcare professionals and patients, and how healthcare professionals in Canada are raising the option of MAID unsolicited, may put undue influence, so coercion, on those who lack support and feel a burden into considering they are better off dead. I'm also, and I will get to that at some point, part of the committee that have just come out with the coroner's reports of October of this year, looking at trends and cases and having studied the health records. However, I'm diverting here just a little bit to tell you that there was an investigative journalist, Alexander Rakin, who is about to release an article within a day in the New Atlantis, and he has given me access to all the reports that are from the Chief Coroner of Ontario from 2016, 2018, 2020 until now. So before expansion and now, in which I can get to as well. But getting back to that power imbalance of raising MAID unsolicited, access to palliative care, like Dr. Green says, does depend on medical diagnosis, where you live and your socioeconomic status. And so Indigenous, incarcerated, and homeless people, as well as disabled and children, get less quality palliative care. Multiple studies, which I can submit, have shown that a lack of access to palliative care and high symptom burden are among those granted MAID in Canada. The accuracy of government reporting about the provision of palliative care has been called into question by many palliative care experts in Canada because they are based on MAID providers ticking a box saying that palliative care was provided. This does not talk about the length or quality of palliative care. There is one case right now that I did review the health records of a battery charge that's going to court, and palliative care was ticked off by the MAID provider, and I did not see a palliative care consult. However, even though the Health Canada reports are extremely flawed in their process of data gathering, they still report that 21% of patients only received palliative care for 2 weeks before they received MAID, which is likely inadequate and means that they were likely granted palliative care only after they requested MAID. Lastly, choosing to die from MAID in the face of lack of timely quality of palliative care and supportive services is not a choice and should be considered a medical error. Polls show that the majority of Canadians prioritize expanding palliative care services over MAID, and that they are concerned that MAID will replace social services. Thank you.
Thanks.
Thank you. And I think Dr. Green wants to come back in.
Yeah.
Sorry, we can't hear you.
Yeah, Dr. Green, you wanted to come back in on this point?
I did, yes. Just so you know, we can barely hear your microphone. I appreciate the chance to talk again. I'm going to be keeping my remarks short, concise, and evidence-based as much as possible, and not based on anecdote or flashy headline or one report here and there. I do want to address the comment about reduction in funding or perhaps diversion of resources away from palliative care to MAID. I think that's wholly false. I think since 2016, since our law has been in place, palliative care has enjoyed probably the greatest increase in utilization in Canadian history, with dramatic new investment in palliative care by our government. Just a few examples for you. The federal government gave $3 billion to home care as part of the new health accords in 2016. That would have been a big boon to home palliative care. Health Canada gave Pan-Canadian Palliative Care Research Collaborative $2.5 million last year for advancing research and building research capacity. The Alberta government gave several $1 million in funding in 2020 to the Palliative Care Institute at Covenant Health to work on advanced care planning. We have seen an unprecedented increase in palliative care staffing levels in most parts of the country. In Ottawa, one hospital, the palliative care division, has more than doubled in size since 2018. And in Ontario alone, our largest province, the number of community hospice beds has essentially doubled since 2016. You simply cannot say that that resources have been diverted from palliative care to MAID. In fact, as in every other legal jurisdiction in the world where we've seen assisted dying, the funding and levels of palliative care have increased since this has become legal.
Just to move this on slightly, it's just also to ask about how palliative care providers in Canada have received this since the legislation has been introduced since 2016. To what extent Has assisted dying been integrated into existing care pathways, and how does that interface?
Who is your question directed to?
To Dr. Green in the first instance, then we'll come on to Dr. Coelho. Thank you.
Certainly. I think there was a lot of fear at the beginning. There was a lot of pushback from the palliative care community. There was a lot of lack of understanding of what MAID is, not just in the palliative care community, but in the entire healthcare community. If you look at national polls, while the grand majority of Canadians, over 80% consistently, year after year, have supported assisted dying, the rates are actually lower in the healthcare community, and that's seen across jurisdictions as well. So, of course, there was some I'll be polite and say reluctance amongst the palliative care community to accept MAID. What I have seen and what we have seen through reports are that palliative care doctors, what I believe, are the most patient-centered clinicians in healthcare. That is part of their ethos. I fully respect that, and I think it's incredible. I think that patients have brought palliative care doctors to this work. I have seen there are many hospices and palliative care communities who in the beginning said they will simply not do this work. That's respected. Our law, of course, allows for conscientious objection or any reason to object from doing this work. But as they saw their patients asking about this information, they would learn a little bit about it. They would counsel them about what they thought it was and leave the work to someone else like myself to come in and do. They then found that they had these very strong relationships with their patients who were asking for this care. And slowly we saw them beginning to do assessments for assisted dying and leaving the provision for others, people like myself, to come in to do. And today we're seeing more and more that some of the palliative care docs are actually now doing provisions as well. There's been a slow change. There are still pockets that were absolutely unwilling to do this work, and that's fine. I think it's not to the benefit of the patient, but I can tell you, for example, the Canadian Association of MAID Assessors and Providers, the group I'm associated with, we have roughly 600 members today. The last time we surveyed them was probably about 2 years ago. Of all of our clinician members, probably 80, I think maybe 75% of our members are clinicians that do the work of assisted dying, and 16% of the CAMAP clinician membership self-identify as palliative care practitioners. In Ontario, where we saw very little numbers of palliative care doctors doing this work, we now see approximately 10% of all the MAID deaths in Ontario being provided by palliative care doctors. So still small numbers, but I think we're going to see more and more of that change over time because patients are driving it.
Thank you very much. Dr. Green, Dr. Coelho.
Yeah, so again, I am speaking on behalf of the Canadian Palliative Care Society, so I will send all the evidence to back what I had said. Going forward, I just want to say, the coroner's reports that just came out of Ontario list the trends and stats for 2023 and show that palliative care access is like 40%. Despite all of that funding, I don't know where it's going. And home care is even worse. The Nova Scotia Health Authority, Dr. Dave Henderson, testified during the committee hearings in Canada that in many places there is no palliative care and MAID is the only option, and that he was asked to train MAID assessors on the principles of palliative care, but in the end they found it too comprehensive and was not what they were about. I can also send you all that evidence from Parliament. And so I disagree.
Okay. I just very quickly ask you, if you had the opportunity to amend the current legislation in Canada in respect to palliative care, what would you want to change in the current bill or act of Parliament?
Palliative care should, sorry, to me or to
yeah, to Dr. Coelho, yeah, to you.
I think that palliative care should be a health right. It should be, it should not be that people are so desperate that it takes so long to get palliative care. In Ontario, again, the coroner stat just came out in July. It is on average 2.2 days to access the MAID team, like to have a MAID assessor, which speaks well to the MAID team. Like I'm not saying anything about that. But what I'm saying is when services take months or weeks or years, people get more desperate. And then if we are talking about autonomy and the choice to die, it should not be driven because people have no other options.
Dr. Green, are you content with the current Canadian legislation, or would you seek to, if you could, amend it or strengthen it or change it in any way?
Well, I would commend it on recognizing conscientious rights. I think that's very important. I would commend it on requiring practitioners like myself to raise the issue of palliative care, to explain what it is, and to offer it to every single MAID requester. I think that's very important as well, and we certainly do that. And I think that's why palliative care access and provision is so high in our patients. I think we're seeing that in the numbers. I think the only thing that I would like to see changed, if I could flag a magic wand, is to recognize that while practitioners and people have conscientious rights, I don't think brick and mortar does. I think tax-funded institutions that choose to opt out of a legally covered MAID service in Canada is probably not good, and so I don't think palliative care facilities should have the right to not do this. That's certainly the state of affairs in Quebec. I think the rest of the country should adopt that policy. And I do recognize that in some places the infrastructure for MAID over the 8 years has been built up to such a point that we are more efficient in some places than in others. I don't think that's a reason to punish it. I think that we need to focus our attention on making sure that every Canadian has access to good quality palliative care, not in reducing access to MAID.
Thank you very much.
Brian Whittle.
Thank you, Convener, and thank you, Dr. Coelho and Dr. Green, for taking the time. Just a very brief follow-up to my colleague there, and I think you hinted at this, Dr. Green. If a patient presents at a doctor asking for MAID, is it the doctor's requirement to introduce palliative care as an alternative option, and is that universal across Canada? If I could ask you first, Dr. Coelho.
Yes, sure. So in the legislation, it is supposed to be that a doctor should inform a patient about all their options. However, in reality, in terms of reviewing the coroner's reports, which you all sent to you guys, and you can see, offering options depends on what the MAID provider has expertise in. So, or the doctor. Like, it might not be a MAID provider we're talking about. It might be if the patient raised it to their family doctor, and their family doctor is limited in terms of their understanding of care systems. Then you can have a situation where a patient might not know about their option to access palliative care, or it might be inaccessible because of where they are, because of rurality, or because like they are homeless, or because of et cetera, et cetera. So although the bill is meant to inform about options, it does not have to be accessible.
Thank you. So, Dr. Green, would you suggest that you suggested that it's a doctor's responsibility to introduce the option of palliative care if a patient presents with MAID? Is that universally across the whole of Canada, and is that provision consistent?
I would say so. I'd say that any MAID practitioner, not the family doctor, not the oncologist, but any MAID practitioner who's asked to do an assessment for MAID, the requirements of that are laid out in the criminal code of our country. We are very aware of what we are required to do and the penalty for not doing so. On top of that, there are provincial standards of practice that we must adhere to, all of which require us to raise this option with our patients and document that we've done so. I believe that's happening across the country. We teach practitioners to do that. They are aware of the law. They're aware of the practice standards. We see in the numbers, in the national reporting, every single case must be monitored and reported with annual reports. We see those high numbers of patients accessing and receiving palliative care because of this requirement. I don't think there's any other explanation for it.
I would like to comment, if I may.
Okay. Go ahead.
Thank you. I understand what Dr. Green is saying. I would like to say that in terms of the coroner's reports, and Dr. Green was the president of CAMAP, so she should have had access to those reports. She would know that there were violations of compliance in 2016 and 2017 to the point where the chief coroner gave a talk saying that he couldn't continue just giving education for non-compliance. He introduced a level system. According to the reports, we're at over 400 violations. This is in the jurisdiction of Ontario, which I think has the best oversight. I haven't seen any public reports from BC. The End of Life Commission in Quebec does a very good job of getting stats. But speaking of palliative care, since it's relevant, they released their report 2 weeks ago, where they said that the MAID death rate is now 7.3%, and they cannot from the data collection, decide if the palliative care was actually administered or adequate. The Health Canada reports, as I mentioned again, are self-ticked checkboxes. They are unlikely to reveal non-compliance with the law or abuses. And in the cases that we've reviewed and in the trends that I've stated that have been reviewed by a team going through the charts, the rate of palliative care is much lower, which actually fits with other academic studies that have been done by palliative care doctors on the quality of palliative care and services that are being offered to patients before medical assistance in dying.
There's zero objective of quality care.
Gillian Mackay.
Thanks, Convener, and good evening to the panel. In 2019, the United Nations Special Rapporteur on the Rights of Persons with Disabilities expressed significant concerns about Canada's approach to medical assistance in dying, particularly from a disability perspective. She noted the absence of a protocol to ensure people with disabilities were offered viable alternatives before considering assisted dying. This concern was heightened when the federal government passed Bill C7 in 2021, which relaxed safeguards for patients eligible for MAID, including the removal of the 10-day waiting period and the requirement to offer palliative care options. And most recently, the Office of the Chief Coroner of Ontario published the 2024 MAID Death Review Committee report, indicating that many individuals are seeking MAID due to factors unrelated to medical illness, such as homelessness and isolation, with MAID access notably higher in economically disadvantaged neighbourhoods. Given the alarm generated worldwide by Canada's experience, do you believe that characterisation to be accurate, and have specific protocols or safeguards been introduced to prevent individuals from turning to MAID due to lack of social support or access to complex care? And can I come to Dr. Green first?
Yes, I think we should probably dive into the coroner's reports. They've been mentioned several times, and I relish the opportunity to look at that data with you. You've repeated some of the headlines that have been put in the international news and some of the opinion pieces that have been put forward. I'd like to clarify that the Death Review Committee reports are not showing and not saying the things that you have suggested that they are. In fact, they show quite the opposite. The Death Review Committee reports show that MAID recipients are, in fact, substantially less marginalized than people who die without MAID. And they show that those who die with MAID under Track 2 specifically are no more marginalized than people, at least in Ontario, who die naturally or with chronic illness. Nowhere in that report did it make the conclusion that you suggested. There are people who sit on the review committee who believe that the data makes that conclusion. There is a diversity of opinion amongst the committee members, which is documented in the committee report itself, suggesting that there is a multiplicity of conclusions, but the committee did not conclude the things that one or two people are suggesting that it did, and to suggest so is disrespectful of the committee and disingenuous at best. It's important when you read data that you don't misunderstand it for lack of basic data literacy. And I'll just very briefly explain it to you very simply. If you study a group of people who go to see a neurosurgeon, you will probably discover higher mortality rates in that group of people. More of them will die than in the general population. That doesn't mean that seeing a neurosurgeon increases your risk of dying. Intuitively, we know that isn't true. That wouldn't be a fair comparison. Neurosurgeons see people who are already at significant risk of dying, people with significant neurologic problems like brain cancer. So if a proper study would compare people with the same brain cancer, half of them see a neurologist and follow the recommendations, and half of them don't see a neurologist, then you can compare outcomes and try to determine if seeing a neurologist or neurosurgeon affects mortality rates. It's called the cohort effect, and it's one of the most basic elements required when reading data. It's the same thing when you look at patients who die on Track 2 of MAID in Canada. If you're trying to determine if higher levels of marginalizations are leading to people to MAID, you do not compare marginalization levels in those who have Track 1 and Track 2 MAID, right? That doesn't make sense. For the exact same reason with the neurosurgeon, you must compare people with the same diagnosis who did and did not receive MAID. And when you look at a large group of people, when you do that, when you look at people with diagnoses that lead to Track 2 MAID, say chronic pain or neurologic illnesses, the number one diagnosis that lead people to Track 2 MAID, when we compare those who did and didn't receive Track 2 MAID, we see higher we asked that question. The answer is we do not see higher levels of marginalization in those who receive Track 2 MAID. The coroner reports are very, very convincing in this, and they are very reassuring in this matter. So it's important that we understand it's the illness itself, the underlying illness itself, that's associated with higher rates of marginalization. Socioeconomic deprivation drives mortality. We know that. We know this from lots of other studies. This is not news, but there's no evidence in these reports that show that that is what's driving assisted dying. We should be focused on reducing factors that lead to socioeconomic deprivation reduction, not on trying to reduce MAID. These reports are very reassuring.
Dr.
Do I get a chance to weigh in?
Yep.
Thank you. So first of all, very interesting analysis, Dr. Green. My husband is an epidemiologist and staff at McMaster and Health Research Methods, and he has also looked through this. I welcome you to submit your evidence about the trends. The trends are there. They show that people in Track 2 have less likely to have next of kin, meaning they list often a lawyer or their medical practitioner as their next of kin. That speaks to a lack of social support. 2, there's a higher rate of women to men, which mirrors the findings in the, yes, 61%, Dr. Green. And that mirrors, increased suicidality in women because women, and I'm not sure if you in Scotland have seen that Glamour article, which talked about how women are at higher rates of domestic abuse, rape, trauma, financial marginalization, which is why if you look at certain countries in Europe that have MAID outside the end-of-life context, you see people that usually would do, if they attempted suicide, they would do well with suicide prevention and care, and yet they're having their lives ended. And that is what the UN is concerned about, that we are ending the lives of people who would have benefited from suicide prevention, but now we are seeing them as MAIDable. And I would like to quote the president of CAMAP. She, in an interview in 2023 that I can send to you with Megan Gilmore, said, yes, I understand. I live in Ontario now that people are being approved for MAID on the basis of psychosocial suffering, and they have a disability, but they don't have to be tied together. The intolerable suffering does not need to be related to the disease. So yes, they can choose death for the psychosocial suffering. Last month in the Associated Press, when Maria Chan and Angie Wang released CAMAP forums, where MAID providers were not concerned about the legality of killing somebody for poverty who had a disability, but more about how the press would react to that. The president of CAMAP responded saying, MAID for psychosocial suffering is forbidden. So in terms of trying to square those two comments, my understanding would be that if you have a disability and you have psychosocial suffering, it is okay to die, and actually according to the legislation. And if you look at the 6 cases that are actually portrayed in the coroner's reports, you will see that they are actually people who are incredibly marginalized. The first gentleman in the vulnerability case is a gentleman with largely untreated mental health and addictions, who happens to have inflammatory bowel disease. He goes to see a psychiatrist who raises MAID to him as an option. He starts his MAID journey. Still, the family is concerned, but they're not consulted, and the MAID provider drives him to the place of the MAID provision. Clearly signs of crossing borders and undue influence. The second case is a woman who has disabilities, multiple chemical sensitivities. Because she is poor, she's living in housing surrounded by smells like smoke and marijuana. She gets funding to make her apartment better, but then she is in this tiny space and she's isolated. And she said that she is choosing MAID because of her housing situation. And the last situation was a gentleman who had injury during COVID, isolated from his family, scared about whether he'd ever be able to return to them, ever be able to parent his children, and receive MAID in a time of known, so people who take care of people with disabilities know that in a new injury and disability, suicide rates are high, suicidality is high. But if you actually care for people, suicidality drops and mirrors that of the general population. So he received MAID in a time of transition, and a legislative requirement was not fulfilled, and that there was no expert involved in the MAID assessment. So to say that they're actually reassuring, I would encourage people to read the actual reports to see what they say.
Thank you. My second question, if we could really focus in on the content of this question and try and keep answers as succinct as possible, because I know there's others want to come in. I'm also interested in hearing your perspectives on the key considerations and challenges Canada faced in their approach. How might we in Scotland learn from these experiences as we work on developing our own legislation? Dr. Green.
Number one, just to be straight to the point, I think the number one issue that you can benefit from, and I do commend you on learning from other jurisdictions. We certainly in Canada have done so. We learned from our colleagues in Europe and in the States and other places so that we were able to craft a better system. I think the biggest mistake that Canada made was we didn't have an implementation period. MAID didn't become possible in Canada through voter demand or through any government thinking it was a good idea. It came through the courts. It's constitutional court challenges, and I'm sure you're aware. And once that became a legal possibility in Canada, we did not take the time like the Australians did to train up clinicians and spend the time to get the infrastructure ready. Because of that, it was a bit patchwork in the beginning, and we had to a little bit learn on the fly. I think that would be the biggest thing I would change. And I will keep my comment concise. There are at least 4 comments I'd like to make from the previous comments, but I will simply address one of them because it's just so stark about the sex differences. It's the exact same issue as the neurosurgeon. If you look at the breakdown of the diagnoses that are involved, any sex differences observed in Track 2 MAID in Canada are easily explained by the sex differences in the conditions. You look at the neurologic conditions that lead to Track 2, the most common one is Parkinson's, and in fact, we're seeing Parkinson's happens almost twice as often in men than it does in women. And in fact, we see Track 2 MAID for neurologic conditions more common in men than in women. That makes sense because we know what's driving it. When you look at MAID Track 2 for comorbidities or the other category, the number one illness there is frailty, and we see frailty happening twice as common in women than in men. So yes, for those ones, we see more women than men. Other than those two, there's no difference in sex differences between Track 2 conditions leading to MAID.
Dr. Coelho, on the key considerations and challenges that we should be looking at here in Scotland.
Sorry, I'm trying to make sure I can talk. Okay. So for Track 2, could you repeat the question?
No, it's just on the key considerations and challenges that you faced and that Canada has faced in their approach, and how we might learn from these in Scotland.
I think that having a balanced panel of people informing the government would have greatly helped with the safety of balancing safety and patient access. You have our government funding the Canadian Association of MAID Assessors and Providers, an advocacy group to develop a curriculum. You have people who have been outspoken about access, I think in a very broad way, who have been leading the consultations. You could see in our government consultations that many senators and MPs admitted that they had consulted Jocelyn Downey for information on how to do this. And really didn't take into account, James Maloney, who is a member of Parliament, asked me to be in contact with Health Canada about my concerns about safety, because I take care of marginalized patients and deal with death wishes for the last 17 years of practice. And yet Health Canada never reached out to anybody that I know who deals with chronic care for marginalized people, and instead relied on the evidence of MAID practitioners. One example I can give very briefly in Parliament is Dr. Leonie Herx, palliative care founder, stated in Parliament that she was already seeing concern about capacity. She has done neurology training and family medicine, and she was saying that patients don't have good capacity, and yet MAID assessors and providers are saying that the patient has capacity without a capacity assessment and approving them. She was chided by the MP during that for unprofessional accusations of malpractice that should have been sent to the police or the college. Well, now we know that in 2020, the Chief Coroner of Ontario actually presented to ChemApp when Dr. Green was the president and explained that one of the concerning trends was that there were no formal assessments of capacity in the charts, and yet patients who had been deemed to have not capacity in the charts before, and there was no way to correlate what really happened because the patient was dead.
That's great. Thanks, Convener.
We'll move to Carol Malkin, who joins us online.
Thanks to our guests. I just want, much of this may have been covered, but just for some clarity, I was wondering about the recorded numbers. Obviously, we know that the government has to report on anyone through the MAID deaths. And I wondered if you would perhaps give us a sense of where you think the numbers are in terms of what was anticipated prior to the legislation, and also the rise. We see a rise from 2019 to 2022. If you've considered what might be causing that rise, and just give us some sense of how you feel that is in Canada in terms of the actual numbers. Perhaps Dr. Green.
Yeah, there's certainly been lots of headlines about increasing numbers being shocking or being disturbing, but numbers in Canada for assisted dying are entirely as expected. They are not at all surprising, and they are not at all a sign of anything nefarious occurring. So rates of assisted dying in Canada are sometimes compared to Oregon or California, some of the states where percentages of annual deaths attributed to assisted dying are significantly lower. This is not a reasonable comparison. Back to the cohort issue. Laws and requirements in Oregon and California are significantly different. They require terminal illness. They require self-administration, a number of issues that will significantly reduce the number of people who will be eligible for MAID. So that's not really a fair comparison. I think a better comparison to Canada is to the Netherlands. Their law is very similar to ours. They do not require terminal illness. And importantly, they allow clinicians to administer the death. So it doesn't discriminate against those who have become disabled due to their illness or were disabled to begin with. So there's a larger pool of people who might access this care. Our laws are very similar. Our medications protocols are very similar. I think that's a very fair comparison. And when you look at the percentage of annual deaths in the Netherlands attributed to assisted dying after 20 years of experience, their numbers anywhere between 5 and 5.5% of all annual deaths attributed to assisted dying. In Canada, we are 8 years in. We've got data for up to the first 6 years, and we're seeing that the percentage of annual deaths of all deaths in Canada that are attributed to assisted dying is 4.1%. So we are not as high yet as our colleagues in the Netherlands. Not that we're trying to catch them or anything. Of course, in the beginning, you're going to have 1% and then 2% and over the years 3 and 4%. So you have to take into consideration, first, the population has to become aware of the service. Many people were not even clear that assisted dying was legal in the beginning. You have to then build the infrastructure and put it in place. Many provinces, like I said, didn't have an implementation plan and didn't start doing that till well after the law was in place. You have to have clinicians who are trained up, have clinicians not only trained but get involved. There's a number of issues that have to happen in order for the greater population to have access to this care. So to see that climb over the years, like any other medical care that's introduced into the system, is absolutely expected. And our numbers remain lower than any country with a comparable law. I am also compelled to point out that actual numbers are irrelevant, of course, because there's a value judgment being added here. Let's say we believe heart attacks are bad. If the rate of heart attack is increasing, we should maybe be worried about that and try to do something to bring it down. But that's because we've made a somewhat non-controversial value judgment that heart attacks are bad. If you think assisted dying is bad, there is no good number. The right number, if you can call it that, is when we take all of those who request the care, and after a rigorous assessment, which includes an exploration of their reasons, their alternatives, including palliative care, and the offer of other resources, which is all required by our law, some of them are then found eligible. And when this remaining group of people who are now eligible are then able to access and receive the care, that's the right number. It's a question of choice, not a question of number.
Thank you. Would you like to come in? Yeah. Thank you.
Thanks very much. So actually, I'm from Quebec, and so I was there when initially the Quebec decided to go forward with expanding to this, and they had the Select Dying with Dignity panel, in which I participated in. Gaëtan Barré, a Quebec politician at that time, estimated that there would be less than 100 requests per year, and that this would be an exceptional procedure for people that there was nothing left to be offered, and that for sure palliative care would be a safeguard. Now in Ontario, so I've shifted provinces. Actually, Quebec has a higher rate, 7.3%. We are averaging 400 cases of completed MAID a month. 4,600 in 2023. If you look at the provincial tallies that have come in across for 2023, even though we're still expecting our Health Canada report, we are at around 15,300, I think. I agree with Dr. Green that the numbers don't matter per se. But what I would like to reiterate is the numbers matter if it is driven by desperation, and suicide prevention is still a priority for our Canadian society. And I am very concerned. So I'm disclaiming, I work in a place with poor people who have poor access. I am seeing atrocious cases of MAID being approved that make me very sad. And when I joined the coroner's committee, it was shocking me to understand that there are batches of cases. Those cases that we released are very similar to the cases that I'm seeing where I practice. And he chose those cases for us to review because they are recurrent practice patterns. And clearly you can see in those cases that people are choosing MAID who don't have other options. And that is very worrisome to me. So the numbers are worrisome to me, but it's because I think we have a lot of health and policy, societal failures that make people desperate. And so if MAID is to be safe, it has to actually be safeguarded.
Thank you. I think some other colleagues have some questions around sort of safeguarding. So I'll go back to the convener. Thank you.
Thank you very much. I'm just very conscious of the time. And so can I ask colleagues if they can keep their questions concise, but also if our panel members can keep their answers very concise and to the point. Before I start asking my questions, I'll put on record my register of interest. I hold a bank nurse contract with Greater Glasgow and Clyde NHS. How confident are you that there's adequate evidence base for the substances used in assisted dying in Canada? Dr. Green?
In question, there's absolutely no evidence whatsoever because these drugs are not used for this purpose beforehand, so there's no randomized control studies or data or published bodies of evidence for this particular use, so it doesn't exist. Except for what we know from the Netherlands. So we do know that we've used their protocol. They've got 20 years of data with it. We see no complications with the IV protocol. It's 100% effective when it's in the intravascular system. We know that from them. We know that from our own experience. So I think you're perhaps alluding to some odd comments by a clinician in the United States, which talks about different drugs.
Dr. Green, I'm not alluding to any comments. It was a question I asked. Then
I would point you towards CAMAP's rigorously reviewed papers on the IV protocol and the oral protocol that's used in Canada, where it comes from, why it's used, and the background information for it.
Okay, thanks. And in terms of that, when there are complications, if there are complications, are professionals allowed to intervene, and what training do they receive and how to respond?
Yes. So as you probably know, 99.9% of all cases of MAID in Canada are clinician administered, and they're intravenously administered. And as I said, when we're in the vein, there's a 100% success rate. There's no failures that way, unless you blow the vein, in which case you have to create IV access. In terms of oral MAID, there's the potential for failure, but actually, our cases are less than 30 across the country, so I don't think they're helpful. We would look to our colleagues in Australia, where they've got more hundreds of cases where they have a 0% failure rate. But in answer to your question, question, in the province I work in British Columbia, it is required for MAID practitioners to be present during the MAID provision, whether it's intravenous or oral. That's there to ensure that things go safely and well. And we do have the opportunity to step in if there is a complication to rectify that issue. There's zero evidence of complications on IV MAID.
Okay, and can I ask
and
then,
too few on oral.
in terms of the security and safety of the of where
Medication?
substances are kept,
Yes.
so it would be the administering physician or the administering healthcare professional who would be responsible for ensuring the security and safety of those drugs prior to use.
It's required that I actually go to the pharmacy to pick them up and sign for them and check them. I take them to the patient, I administer them or watch them administer for themselves, and I must take that back to the pharmacy and sign off again. So I am legally responsible for those medications and I sign for them. Yes.
Grant,
correct.
thank you very much for that clarity. I'll now move to Elena Whittam, who also joins us online.
Thanks very much, Convener, and good evening to our panel this evening. Just to declare an interest that I am a Humanist Society of Scotland member and I'm also a Canadian citizen. The first question I have is round about coercion and safeguarding, and in the interest of time I'm going to join them together, so I'll just have one question in total. So like the proposed bill that's in front of us, Canadian law does seek to prevent coercion. So I would like to know what measures are in place to ensure that only those who fully meet the criteria have access to MAID, and if we can keep it to kind of track 1 MAID, as that's the law that will be in front of us, we don't have a track 2 option. And I guess the second part of my question is really round about the specialist training. So how do we ensure that doctors who are providing MAID are adequately, trained to assess coercion and to make sure that that safeguard is in there? And if I could start with Dr. Green and then go to Dr. Coelho, please.
I'll just be very concise. There is zero evidence the MAID patients. I think we can all agree that Twitter stories or catchy headlines in the Herald or the Daily Record are not evidence. I see far more examples of people being coerced out of accessing MAID by their loving family and friends than coerced in. In my several hundred cases, I've seen 2 cases where I truly thought there might be an element of coercion happening. One of them I was able to satisfy that it wasn't, and the other one I found ineligible. You're asking whether clinicians know how to do their jobs. We certainly do, and we certainly now have training in place to teach about how to look for coercion, and not just explicit coercion of angry people or greedy family members. That's more obvious coercion. We also teach about more subtle forms of coercion, teach about looking at vulnerabilities, teach it looking for marginalization, how those things might be involved in a patient's decision. So the training for that, we came to a little bit later. My colleague mentioned the Canadian MAID curriculum, CAMAP, which is clearly not an advocacy group. I'll just say we are subject matter experts. We were consulted by Health Canada in order to make this training program, which is now available. There's a whole section on how to train clinicians to deal with coercion so that we can maintain the fact that there is zero evidence of this happening in Canada.
Thanks very much. Dr. Coelho, do you want to come in as well?
Sure. I will submit, because I didn't get a chance to answer, but the coroner has actually made reports on failed MAID cases by IV in Ontario. There have been cases that have gone to the college for that. Moving on to coercion, I think raising it as we, speaking about kind of not quoting headlines, but like sticking to the evidence, we have CAMAP having a bringing up MAID policy. And so you have a lot of clinicians, I'm not talking about just MAID providers, I'm talking about community providers who might even be trying to be helpful, can be repeatedly raising MAID to the same patient, which I think can be undue influence or confirm to them if they're feeling hopeless that their life is not worth living. And that's the opposite of autonomy. In terms of the coroner's reports on coercion that they need to send out to CAMAP MAID providers in Ontario because of recurrent cases, there have been lessons learned on voluntariness. So in May, and this will be in the article from the New Atlantis, and I think was released also by Maria Chang, the lessons learned were sent to all the MAID providers in Ontario because there was a gentleman who set up his wife's provision. And as a side note, the coroner mentions like this really calls into question the voluntariness of her wanting to have MAID. There are other cases of duo euthanasia where one partner seems to be wavering and they've cancelled MAID and reset it up. There's been cases of spouses who are burning out and actually have done the MAID coordination. All of these things, actually, I will send you from the coroner's office. I think that, it's very nice to say we have no coercion, but we have no robust safeguard to prevent coercion in real time. And that is very scary to me. And as someone who just being human, understanding discrimination and the way that people can treat certain types of people as being less worthy of care, I don't think that there's any evidence that there is not coercion. In fact, I will send you the evidence that there is.
Thank you. Convener, I have other questions, but in the interest of time, I'll pass back to you to go to colleagues. Thanks.
Thank you very much. Emma Harper.
Thanks, Convener. Good evening to you both. Thank you for being here. I'm just going to pick up on the issues around training and education required, not just in terms of training to identify coercion, but just training in general. Can you tell us a little bit about what has been set up? And then also, one of the issues that came up last week was that the proposed bill in Scotland just identifies a registered medical practitioner. So that could be foundation year 2 doctors all the way through to consultant level. So tell me about your process in Canada in terms of education and training. I guess Dr. Green first, I suppose, or Dr. Coella. I'm not.
Yes, ma'am. Sure. So as I mentioned in the beginning, there were no formal training programs. It's the opinion of most clinicians that medical training and nursing training provides people with the skill set to practice medicine, and that we already use these skills in our everyday practice. We assess capacity and voluntariness in every interaction with every patient multiple times a day. We can't give a medication to a patient who doesn't understand what it's for or what their alternatives are. There's higher levels when it's surgery. There's higher levels when it's whether they should start or stop dialysis. We can make a huge list of things. Capacity, informed consent, these are standard practices that all healthcare practitioners are trained in. It is, of course, always ideal to have extra training in a field that you're going to be spending more time in. So, as we mentioned, CAMAP's a national professional organization founded to support the diversity of professionals that do this work and to educate healthcare community and practice at the highest of standards. We are the subject matter experts of this, and we have developed a nationally accessible, bilingual, hybrid, online, in-person MAID training program that has 8 distinct modules covering the foundations of MAID in Canada, how it came to be and the ethics around it, how to have clinical conversations around MAID while you're having end-of-life conversations, how to do a basic MAID assessment, how to do advanced capacity assessments and assess vulnerability, how to do provision of MAID, how to approach complicated and complex scenarios, and how to deal with mental health issues when they show up in your MAID assessment. So a very comprehensive program with, if I remember, about 100 different sets of eyes and stakeholders on the content as it was being developed, now rolled out and available across the country free of charge for any licensed medical professional, a medical doctor or nurse practitioner in the country. We're hoping this will help standardize the approach to the assessment and delivery of care. Would it be ideal to have this in the early days? Yes. Are we glad it's there now? Yes. Is it required in order to practice MAID? No, it is not. We do think that doctors and nurses have the skill to do so. We do recommend, however, that people take this course.
And I think Dr. Coella was going to come in as well.
Sure. Yeah, I agree with Dr. Green that there's no formal training required to do medical assistance in dying in Canada, that their curriculum has come late, but they are waiting for funding, not blaming CAMAP for that. Came in 2023. My concern is that, it's very nice to say that we all have training, but for example, capacity requires, from one of my good colleagues, she's the capacity expert of her institution. So when I was at McGill, if I didn't know if a patient had capacity or not, usually for financial issues, I'd be sending them to her and she would spend 10 hours doing a capacity assessment. This is not happening with MAID, which I would say the stakes are higher. very concerning to me. She reviewed the CanMap curriculum and did not feel that it was adequate for the seriousness of the decision-making that was happening. This is not a knock to anybody, it's just a statement. And the same thing with MAID for the curriculum for potentially future mental illness. And in general, Madeline Lee, who developed that curriculum, has raised issues with the MAID, the openness of MAID for psychosocial suffering and things that can be approved. So I would not say that we are in a place where we have a great education or standardization.
Okay, thanks. I'll hold it there, Convener, because I'm conscious of time.
Thank you. Brian Whittle.
Thank you again, Convener. Again, I'll be brief and hopefully if I've time at the end I'll come back in with some other questions. I think you Dr. Quilly, brought up the issue of capacity, that capacity to make that decision. And I wonder, looking at potentially people with dementia who lose that capacity towards the end of their life, is there any provision under the assisted dying law in Canada for people to put an advance directive in place in the situation where they may lose capacity as their condition deteriorates?
Yes, so as it stands right now, most cases, as Dr. Green pointed out, are euthanasia, so a date must be set. It can be pushed back if a person has capacity. If there's fear that someone is going to lose capacity, the current legislation allows for a waiver of consent, where the MAID provider and the patient may enter into an agreement that if they lose capacity on that day, after they've had capacity during their 2 assessments, that they can go forward and have MAID on that day, on that prescribed day. As it turns out, your question's very timely because Quebec has just announced on October 30th that they are going to go ahead, even though it is against the criminal code, and have MAID by advance request period, meaning that a person who foresees that they might lose their capacity prescribes in a written document that they would want MAID at a future date. That will be for someone else to enact. And the federal government has just announced that they're going to do a quick consultation that ends in January, and they won't go after Quebec for this. So it looks like we are expanding to fuller advanced directives. I'm not sure if you want to know my thoughts on that or just where we stand on that.
I'll happily take any insight you can give us.
Okay. I mean, like, I take care of my father with dementia. I also did home care for many years where I took care of people with dementia. And our system is failing people with dementia, like in terms of services. So again, people have a lot of fear. Fear, I think, of cognitive impairment in general because of the way our society is structured and how we see that loss of cognition as a loss of dignity. And may not understand that their future self would be totally happy with dementia, as many of the patients that I cared for. And so the question is, can you actually, as your younger self, predict when you'd rather not be living? Most studies show that people with disabilities who've had time to adjust, or people with dementia, they actually rate their own quality of life, that is very high. If you have a person who is able-bodied rating what they perceive their quality of life, they perceive it as very low. And that is the problem and the fear for me of advanced directives, that people will be entering into an agreement that will be enacted later by a third party when they might not actually be unhappy. And also that creates a lot of uncertainty for the providers and the family. Like, when do we enact it? There's a lot of questions, like a lot of MAID providers have spoken about this, even from Quebec, very well-respected MAID providers who are very, very concerned about this expansion.
I see you nodding, Dr. Green, there, in agreement.
This is a discussion, a robust discussion that needs to happen in Canada, and I think that will be happening, especially with Quebec's advancement. I mean, the way that Quebec came to this is a completely different system. I'm sure you don't want to get into the weeds of how that is. And we know that Canadians, over 80%, want advance requests, so this is something that we're going to have to grapple with. I think it will be years before we see it in the rest of Canada, and we'll be looking carefully at what Quebec has done and what's worked and what not worked. This is the next robust discussion to have in Canada. There are certainly mixed feelings about it, and I look forward to the discussion.
Convener.
And Joe Fitzpatrick.
Thank you, Convener. I'll be quick. One of the areas, one of the arguments that's sometimes made in support of assisted dying is that without a lawful alternative, people might choose to die by suicide. So I think it's an area that you touched on earlier, Dr. Coelho. So just really to hear your views on whether that you have seen a difference. Has there been a reduction in folk using suicide as a way to end their lives now that there is a legal alternative? Dr. Calero, as I said, you mentioned it earlier, so do you want to go first?
Dr. Coyle, okay, yes. So the Canadian Association of Suicide Prevention has been very vocal on this. There are concerns that assisted suicide is just basically usurping the previous role of suicide prevention, especially outside the end-of-life context. That people who traditionally would recover from a suicide attempt with care and go on to enjoy their lives and heal are instead having their lives ended at their worst. And again, I encourage you to read the case reports that are included in the coroner's report. In terms of evidence overseas, David Jones, who's in the UK, I think, has written extensively on this, and I can send you his evidence. That looks like, that is an argument that I heard initially that, if we have MAID, we'll reduce bridge jumping and people using guns, and this will be like a better way for people who would commit suicide anyways. My understanding is that the data in Europe does not show a reduction in suicides. And I'm very concerned that we are just basically, instead of helping people have hope and look for options to live, like the Human Rights Commissioner of Canada has stated twice, that instead, for lack of supports and care, we are ushering them to a premature and wrongful death.
Okay, thank you. And Dr. Green?
Yeah, two very brief points. Number one, I think it's important to clarify terminology. If you look at suicide prevention organizations around the world, they themselves have said that conflating suicide and assisted dying is not just unhelpful or damaging. And I quote the one from Australia, it says, "It is inappropriate and insensitive to characterize a wish for an assisted death as being suicidal." You will no doubt hear from witnesses coming forward in your work and using terminology, talk about doctors killing people, talk about using assisted suicide. These are not terms that we use in Canada for obvious inflammatory reasons. But in direct answer to your question, in Canada, if you haven't already seen the graph, rates of suicide were slowly increasing until 2015. Since then, and particularly as MAID numbers have climbed, as we have alluded to substantially since that time, suicide rates have actually started to fall dramatically. They're currently at the lowest rates they've been in my lifetime, possibly the lowest ever recorded, and I have a chart for that if you haven't already seen it.
Thank you.
Brian Whittle.
Thank you, Kavita. Just a very quick question. It's been very helpful to have two different sides of the argument here, and I thank you both for doing that. I think one of the things that was raised there was around coercion, and one side of that was almost like coercion to prevent people taking part in MAID. And I just wondered, has there been any legal response or legal cases post some patient accessing MAID, or is there any figures around that sort of? I'll come to you first, Dr. Green.
Yeah, so we don't have national figures on that because it's not something that we record or are required to report, so we don't have national numbers. We have seen a couple of court cases. There's one I'm just thinking of offhand from Nova Scotia where there was a man who was applying for assisted dying. His wife very much didn't want him to do so. She couldn't convince him not to. He wanted to go forward, and it was planned, and he was found eligible. She went to court to try to stop him, and the court decision was quite clear on the reasons why she wasn't eligible to do that, didn't have standing in that. There was another case in Alberta, and I feel like there's a third case I can't think of right now. So we have snips, little pieces of evidence that this is happening, and people trying to go to the courts to prevent things like that. But we don't have national numbers on how often that happens. I can only tell you anecdotal evidence. I've seen somewhere between 400 and 500 patients to accept them for assisted dying. I've seen very, very few where I was worried about coercion into this. I think that is something we can assess quite well. I have seen probably 5 to 10 times that many people convinced not to go forward, even if they've been found eligible, just asked for their family and friends' sake to stick around longer.
I don't know, Dr. Quell, have you anything to add to that?
Yeah, a few things. First, I just want to clarify that I was talking about MAID outside the end-of-life context, the previous question. For this question, for family members, so we don't live in isolation, this kind of false construct of autonomy. a family member who is distressed that a person might die, it could be that they are coercing them not to die. It could also be that they're concerned that the MAID provider has overstepped their powers or are abusing the legislation. In the Nova Scotia case, if I remember correctly, the gentleman had 7 assessments before he was approved, which shows that he could doctor shop until he found 2 favorable assessments. For the case in Alberta, the lady with autism that's been replaced in the news, there's also concerns, a very concerned father who's been vilified by the MAID community, who is trying to prevent what he considers to be the wrongful death of his daughter. And the third case, I think that Dr. Green one was the one that's happening right now, is a woman who has mental illness and she has akathisia, so she has side effects from medications, who her own doctors in Alberta did not think she qualified. She contacted via video conference a doctor in BC who approved her through video assessments. She flew to BC to get MAID, and so the family and friends got an injunction from a judge that day. Given that there doesn't look like there was due process, the second assessor was set up by the first assessor. They are supposed to be independent, and there is question about whether these things are actually an irreversibility decline of capability, actually a prize to akathisia that hasn't had proper trials and treatments. So there has to be an understanding that this is a very complicated discussion, and families love I hope they love their family. And so sometimes when families are trying to not get their loved one to die, it's because they see hope that maybe a practitioner can't see because they don't know them as well.
Thanks, Convener. It's just a thought about going back to the participating physicians. Is there any data on how long a physician has been practising, as in the proposed legislation we have is that junior doctors, that we would consider junior doctors, could be making choice of helping somebody assist them for their end of life. And also I'm thinking about the people, or the medical practitioners like nurses and pharmacists and doctors, who might feel coerced into providing support when maybe they want to just, conscientiously object. Do you have data about that? I think Dr.
Yes, so we don't have numbers of people who conscientiously object, but we definitely have an explicit line in our federal legislation allowing for and respecting conscientious objection. That goes to pharmacists, junior doctors, older doctors, nurses, anybody at all in healthcare can choose not to participate in this care, and that's absolutely respected across the country. We don't have a minimum of time that you need to be practicing in order to qualify to do this work. We set the legislation, nobody set, the legislation set the bar at people who are licensed to practice through medical licensing or nurse practitioner licensing. Provinces can set their own standards if they wish, but that's the federal. And I would encourage, just with respect to the last question, that if anybody's actually interested to read the response to the Sorensen case in Nova Scotia, to make it clear, and to not presume that anybody knows anything about the other cases, because of course we're only hearing from the newspaper one side. So I don't presume to tell you the details of the cases, even though I might know some of those details.
Okay.
May I answer?
Yes, thanks.
Yeah, okay. So yes, as Dr. Green said, our law has a direct kind of legislative requirement that no doctor is forced to participate or assist. That has been taken mostly to be in the actual provision. So actually, there was a press release by a group of doctors who are worried about bullying, but who came forward saying they feel pressured in hospices to be the most responsible provider. Ellen Warner, an oncologist at Sunnybrook Hospital in Toronto, testified about ongoing bullying because she's a conscience objector. She's an Orthodox Jew. And someone stood up and said, people like you don't belong in this hospital. You have effective referral in Ontario. So even if you're a conscientious objector, you need to make a referral, which sounds great in principle for a patient. But the way that the model practice standard and the document is written is that even if you have a professional consideration, like you're a MAID provider, but you consciously object because of like psychosocial suffering, And this has actually been released in one of the CAMAP training videos where one of the bioethicists tells a doctor who's a MAID provider he's not comfortable with MAID for psychosocial suffering. He says, well, then you'll have to make a referral and hopefully the next person will do it. And so there are problems with mandating participation when actually finding other systems might actually protect patients better.
There's no mandated participation anywhere.
We have one final question for you both, if that's okay, and I do appreciate that you've stayed a bit longer than you had initially agreed to, from Paul Sweeney.
Thank you, Convener, and thank you both for your persistence and patience with us as we go through some of these complex issues. I just wanted to ask about some of my own constituents' cases that have come up, and often it's discussed in the context of end-of-life care, a matter of hours perhaps out from death, where people, perhaps have experienced the progression of a cancer such as pancreatic cancer or throat cancer. Their quality of life has deteriorated significantly. They may be, verging on terminal agitation, where there's going to be sedation considered. And at that point, they might want the comfort of having the option to end their life at that stage and anticipating that the deterioration is going to follow that course. Is that something you've experience of how the dynamic plays out in Canada, where it's people who are fearing a condition's progression and what it means for their own quality of life, and they want to have that option, they want to have that prior approval as a matter of comfort for themselves as they face a terminal illness with a pretty bleak prognosis, and then they have a point later on that they can then sort of, once a certain threshold has been passed, that they can trigger the end of their life under their terms. Is that something that is that how it plays out? Is that a common characteristic of how it plays out?
Yeah, I'm just going first. I really appreciate the question. I think, it's easy for us to sit here and talk about affecting doctors and laws and ethics and different things, but this cares really about patients. I think it's important that this committee understands why you're even considering assisted dying. It should be patient-centered and patient suffering. In Canada, we're suffering-focused more than end-of-life focused. So I really appreciate the question. It is quite common that we see people come to us, especially at this stage in Canada. People will come to us earlier in their course of illness. Originally, they came quite late, kind of in the situation you described, where people might be literally at the very, very end, probably too late for MAID. The example you give where someone is literally hours or maybe a day away from terminal delirium, that is not an appropriate case for MAID. That's an appropriate case for good palliative care, and that's how that would play out. There's a lot of it. It's a rigorous process to get MAID in place. But I'm seeing lots of patients who come to me earlier on. They tell me what's important to them. They tell me what is meaningful in their life, what still brings them joy, what they've lost, what they want and why they want it. And after a very rigorous process, there are times when I can tell them, yes, in fact, you are, in fact, eligible for MAID. And I see the transformation. It's physical. I see it almost every single time. The patient will then relax. They will no doubt express their gratitude for the option, for the mere possibility of an assisted death. Their level of suffering literally goes down. I expect, although I don't have data for it, that they actually will live longer because they know they have this trump card in their back pocket. And I see them immediately shift from focusing on their fear of how they're going to die, because let's face it, that's why they've come to me. They are scared. They are scared of their decline. They're fearful of what their death will look like. And now that they know they have this option, they immediately start focusing on how they're going to live the rest of the time they have left. A significant portion of them will never choose to have an assisted death simply because their suffering has gone down with that possibility. And a larger majority will go ahead and actually set a date and proceed with MAID. So that's really what we're seeing. We're seeing the therapeutic value of these conversations with patients, open and honest conversations about true end-of-life options that may or may not include palliative care, that may or may not include MAID, and a whole bunch of other resources. So they want the possibility that is therapeutic in and of itself is what we're seeing.
Dr. Keller, I just wonder if you had a perspective on that, maybe late-stage option that people want to retain, that sovereignty.
So most international evidence and consistent with Canada shows that people choose MAID earlier, and they're choosing it highly cited internationally out of fear of being a burden. You look at the Health Canada reports, fear of being a burden, loneliness are high up there in the top 5 reasons that people are choosing MAID. So although I understand the scenario that you're painting, If you look at the first 100 cases of MAID deaths that were approved in Ontario, this is in track 1, like before there was an expansion. Things like anorexia, grieving, things that I think are not the kind of autonomous kind of setup that you're thinking of are actually what's playing out a lot in reality. I just want to say, like Dr. Green, I understand like your practice is good. I've heard it from other people, but I don't think other MAID practitioners necessarily have the same practice standards or patterns, which allow for a lot of other people being approved for MAID, and as I consider it, getting a wrongful and premature death when they should have got care instead.
Thank you. Can I thank both of you for joining us today? I think you have certainly given the committee a lot of food for thought. I really do appreciate your time, and I'm sure your evidence will help us in our consideration of the bill. Thank you.
Thanks for having us.
Thanks for having us.
At our next meeting tomorrow, Tuesday, 12th of November, we will continue taking oral evidence as part of the committee's Stage 1 scrutiny of the Assisted Dying for Terminally Ill Adults Scotland Bill, and that concludes the public part of our meeting today.